Well, hello everyone. This is Sharon Byron from TrueCode, and I'm so happy to welcome you to today's webinar, Coronary Artery Procedure Coding in ICD-10 PCS, which will be presented by Lynn Kuehn. I hope everyone is staying healthy and sane during this difficult time. I know many of us are confined to our homes, but I'm happy we can get together virtually this afternoon for some awesome coding education. I think a lot of folks on the webinar today are familiar with TrueCode and the webinars that we offer, but for those of you who may be unfamiliar with us, I wanted to just take a minute to introduce TrueCode. We offer encoder technology that's used by many, many hospitals, consulting firms, and payers. And we're actually celebrating our 15th anniversary this month. And in fact, Lynn was one of our very first customers way back when. So she is an original TrueCoder, if you will. If you've never seen how TrueCode works, I encourage you to register for a demonstration, which you can do from our website. We have a unique approach to coding, makes it very intuitive, and it can really have an impact on your coding productivity and accuracy. So encourage you to check that out. Okay, now I would like to introduce you to today's presenter, Lynn Kuehn. Lynn is the president of Kuehn Consulting, and she has over 35 years of experience in areas including coding and reimbursement systems and data quality reviews. She has authored multiple books for FAHIMA, and is also the developer of the popular seminar series, Advanced ICD-10 PCS Skills Workshop. Lynn has also authored online coding courses for LIMA education. She's a registered health information administrator, a certified coding specialist for physicians, and a fellow of FAHIMA. So we are so happy Lynn could join us today. And before I hand it over, I just want to review a few housekeeping items to make sure this is successful for everyone. First, everyone's in listen-only mode, so that means you'll need to use your control panel if you have a question. This is the panel on the right-hand side. You can minimize it to your screen better, or you can collapse and expand it by clicking on the little red box with the arrow. If you have a question, there's the question section of the control panel, which you can open up. Just submit a question that way. We will be monitoring the questions throughout, and then at the end of the webinar, we'll try to answer as many as we can. So please feel free to ask a question at any time. And lastly, I want to point out that handouts for today's presentation are in the handout section. They were also emailed in a email that went out yesterday. So hopefully you have those accessible to you. And then most importantly, we want to make sure you receive your CEUs. So tomorrow morning, we'll be sending out an email to all attendees, and that will have a link to a brief webinar evaluation. You can complete that evaluation, and once you submit it, you'll be able to download your CEU certificate. So if you have any questions or you have any problems, you can always respond to me, but that is the plan for CEUs. All right, with that, I'm going to hand it over to Lynn.
Great, thanks, Sharon. All right, today we are going to work on all things coronary artery. We are going to look at the coronary artery bifurcation, which I know has been a problem over the years. We're going to work on dilation procedures with that bifurcation. We're also going to look at basic coronary artery bypass coding to set the stage for the more unusual coronary artery bypass procedures that I'll talk about. And then, as a view of coming attractions towards the end, we're going to compare and contrast the surgical techniques used in open versus percutaneous endoscopic CABG procedures. So with that, we're going to start with the bifurcation today. The bifurcation really is, according to Webster, the point or area at which something divides into two branches or parts, or the point at which bifurcating occurs. I like to just think about it as the fork in the road. And it really looks like that. We're going to look at some images, and I have some graphics that will show you that you can actually see a V when you look at the arteries. So I don't know exactly why bifurcation has been so scary. I even have some coders that say, well, I just never assign that because I don't know what to do with that. So my job today will be to take the fear away and to give you a whole bunch of examples that you can use when you need to code the bifurcation. And what I'm talking about is actually the qualifier that is here. When you are in heart and great vessels and dilation, you will find bifurcation qualifier value 6. And so this is our subject. Now, I did want to remind you that when you're using TrueCode, the easiest way And the fastest way to get to the tables is just to put a 0 on the line and to click enter. And so you'll see a couple of screenshots of TrueCode today. And I just wanted you to know that you do not have to take the time to go to the index. You can go 0 and you can just pick all 7 characters and you'll be done. All right, so now the bifurcation, I chose to show you the 0-2 table for heart and great vessels because as of last October 1st, the bifurcation qualifier is only in heart and great vessels. They got rid of it everywhere except there. And CMS just said that in the past they'd received a request to put that qualifier for all of the arteries. And they actually finally figured out it really didn't belong in upper and lower arteries. And so they took it away. We still can deal with what we need to with the bifurcation without the qualifier. And we always follow guideline B4.1C when we're working on upper and lower arteries. And that's that guideline that tells us to go to the furthest location from the point of entry when we're coding procedures on a continuous section of upper or lower artery. All right, so now to understand this bifurcation thing, we need to do a quick anatomy review because I think the more we understand about it, the less scary this will be. So coronary arteries are our subject, and there are 2 main ones. There is a big right coronary artery that goes down the right side of the heart, and then the left coronary artery that comes out behind the pulmonary trunk. Now, those 2 are the big ones. Then they branch off into smaller branches that have names for the most common anatomy. Now, it's only fair to say that you'll even read in some heart cath reports that the patient has an abnormal artery, has an aberrant or variant anatomy, and has very small, normal coronary artery branch versus has some branches that no one else might have. So this is kind of the standard anatomy, if you will. The right one that goes on the right side of the heart has 2 smaller branches, a right marginal and then the right posterior descending. And on the graphic that comes next, I will point out how that one kind of comes down and around to the back side, bottom back side of the heart. Then the left coronary artery branches into 2 other kind of middle-sized arteries, the left anterior descending that goes straight down the middle, like along the left ventricle, and the circumflex that goes around the left atrium. They each have a number of branches, and again, that is dependent on the patient's own anatomy. So this is a graphic of a heart that will help us to know where we're going because it really helps to know geography while you're trying to visualize what's happening in the heart. And it does help if you have a picture available that's labeled fairly well so that you can get the roadmap of what you're trying to accomplish. So I have circled for us the 5 big bifurcations of the heart. I'm going to start on the right side of the heart, which is the left side of your screen with number 1 and work around. Number 1 is the bifurcation of the right coronary artery where it branches into the right marginal. You can even see how it looks like an upside down Y for the fork in that circle. Then number 2, you have to look carefully. It's that posterior descending, where the right coronary wraps around the back and bottom of the heart. So there is 1 bifurcation way in the back, hard to get to. Now I'm going to go out of order. I'll get back to 3 in a minute, but let's go to 4, moving across the heart. The left anterior descending comes straight down the middle, and it has a large bifurcation there with the diagonal branch. Then number 5, this is the circumflex that comes around the left atrium, and it is shown branching into the margin branch or marginal, depending on which artist you look at. So those are the places in the heart where there are a bifurcation with 2 forks. But now let's look at number 3. Number 3, up towards the top, is the one place within the heart where the coronary arteries branch into or have 3 arteries that are involved in the bifurcation. The only place that I can find in the heart. So the left main is kind of grayed out there as it goes behind the pulmonary trunk. And as it comes out from behind there, the left main actually stops. And 2 new pathways pick up, the left anterior descending and the circumflex going around. So this is actually the junction of 3 different vessels. Think about it as sort of like highway intersections. The number or name of one highway quits, and it turns into 2 options for you in which way that you can go. But that's really the intersection of 3 highways right there. So these are the major bifurcations that you need to know about for standard anatomy. Now, as we move on now from here to talk about the dilation procedure and the bifurcation, it's important to remember that these procedures are done percutaneously. They use catheters and they use contrast and imaging to see where they're going. They enter either at the femoral artery or at the radial artery, kind of surgeon's choice, and we don't care where they enter. We just care where they go. This may be done at the same time as a left heart cath, and we're going to code that left heart cath along with any of these procedures. It would just be not probably the principal procedure if they do an intervention. There would also be that imaging, and we're not going to discuss the angiography today. You will follow your facility policy on whether or not you code angiography. That is facility specific. All right, so as we start the angioplasty process here, it's important to know that we still count coronary arteries the exact same way we would if there was no bifurcation. We are going to assign the body part value based on the number of arteries that are treated, and the qualifier then will be 6 of bifurcation when we're working on a lesion at the bifurcation. Now, many times, as you know, they're going to put stents in place after a dilation procedure, and we're going to code the number of stents used to treat the lesion at the bifurcation. With that said, I do also want to remind you that you may have to itemize your codes because they don't always treat all of the arteries that come together at the bifurcation in the exact same way. And that means they didn't use the same device, the same qualifier, so we'd have to itemize, okay? And I'll show you that in these examples. All right, example number 1. And I have the art for us so that you can see what the bifurcation looks like as we're starting to code it. Case example 1 says 2 drug-eluting stents were placed percutaneously, 1 in the circumflex and 1 in the obtuse marginal branch via the T-stent technique. Now, I get questions on this one that coders say to me, I don't know if that's the bifurcation or not. Well, you need to look at the artwork. You need to look to see. Yes, the obtuse marginal does branch off the circumflex, and really the only way they can use the T-stent technique is to have 1 stent in 1 vessel and then place a second stent perpendicular or as a T into the branch. So the T-stent technique is a huge clue that we are working right there at that bifurcation. So if they used 2 stents in 2 arteries, we're going to be able to use 1 code to get this job done. And then I might as well just say, when I code these, I always have to double check I got the right body part value because whoever developed the system, they did not match up the body part number to the number of arteries treated. Terribly frustrating, but you will get used to it. And so if we have 2 arteries, the value is 1, and it always seems naughty to me that they did that. But here is our code. And we have two arteries that we can capture then within one code because they treated them the same way. All right, now, example number 2. This is that one place in the coronary arteries where we can have 3 arteries that are together. Okay, so 3 different names of arteries. So it says here, the lesion starts in the left coronary artery, that left main as it comes out from behind the pulmonary trunk. And the lesion extends into both branches of the left coronary. They're called the circumflex and the left anterior descending, and you can see the fork there. This lesion was treated with 2 drug-eluting stents. The description tells you that it goes into both branches, and you can see it, that this is a bifurcation. But the surgeon, unfortunately, or the cardiologist did not identify this as a bifurcation, but it is. It's our job based on guideline A11 to interpret documentation and to basically know what's going on in the procedure. So for this one, they probably used a T-stent technique anyway. They probably put one long stent from the left main into the left anterior descending, and then used the T to perpendicularly place that stent going into the circumflex. So here, we can still use one code to get this done, and this is the one location where you can end up with 3 coronary arteries, and they're named there at the bifurcation, so the 6 is there on the end, and then the device value is 2 drug-eluting interluminal devices. All right, now let's take a look at that same piece of artwork. Oh no, I moved it down. I moved down the left anterior descending to the next fork in the road, okay? So left anterior descending, but this time the branch is into, I think, the diagonal branch. Yes, diagonal. A drug-eluting stent was put percutaneously into the left anterior descending, the big one. So that means they had to dilate and put the stent. And then the documentation says they just did angioplasty in the diagonal 1 branch. So this is the clue that they did things differently in both arteries. And this is where we're going to have 2 codes for this, but the number of arteries treated equals the number of arteries treated total. We're itemizing out, so both of these codes have 0 as the body part value, and only one of the codes has the 6 at the end, because there's only one bifurcation here, okay? So there don't seem to be any rules about which code should get the qualifier bifurcation. So I tend to put it on the one that uses the device, if there is one like that. So there should be one. So the drug-eluting stent goes on that with a 6 on the end. And then the other one is just for the dilation with no device left in place and Z, no qualifier. So together, they add up to tell the story of this bifurcation that was treated differently in each vessel. Okay, now, next one, case number 4, this one's a little bit more difficult, and I will tell you that this is an absolutely real case. And what has happened here is the coder has assigned a code that I don't think tells the story of what's going on. The interventional notes say that there is a proximal left anterior descending segment with a 70% stenosis. Then there's a proximal circumflex segment with 70% stenosis, and a mid-circumflex artery segment bifurcation. And they actually said that in the documentation, and that one has a 75% stenosis. So they're going to treat all of this with the Resolute Onyx stent, which is a drug-eluting stent. The original code assignment for this said that 3 arteries were treated with 3 stents at the bifurcation, which is really not the story I think we need to tell. So here's the artwork. We have a blockage here in the proximal LAD, a blockage here in the proximal circumflex, and then what has to be a blockage at the circumflex, the mid-circumflex, down to the marginal branch. It doesn't name it, but that's what it has to be. And these are 3 distinct places. They don't name it. They also don't say that they did anything in this other branch. So we do need to account for the bifurcation, but we're not going to account for 3 arteries, because if we did, that would be here, where I had the circle where 3 arteries would come together, and that's not what happened. So it sort of shows the wrong position. This means that the left coronary artery would have to have been involved with the LAD and the circumflex. Not the case, never mentioned. So let's look at the answers that go with this. I believe it needs to be itemized out that there were 2 coronary arteries with 2 drug-eluting stents, which took care of the proximal LAD and the proximal circumflex, which were unique blockages. They don't intersect unless the left main is involved, and that wasn't involved. So then we need the other code that has the 1 drug-eluting stent that went into the mid-circumflex, and they didn't do anything in the branch. So my suspicion is that just by opening that up and putting in that stent, it then opened up the obtuse marginal to get the blood that it needed. Although I will tell you, it's a real case and it is messy, but I just wanted to point out how assigning the codes incorrectly can tell the wrong story with the codes. All right, one last case on this, and we're going to move over to the right side of the heart now, because we haven't been there yet. There is our other upside down Y for the fork in the road. This one, it's a lesion that starts in the right coronary artery, and it extends further down the right coronary, so all along there, and into a side branch called the right marginal artery. There's a clot also found proximal to the atherosclerotic plaque that caused this blockage. And so that's indicated there in red. That's the clot. So they did a mechanical thrombectomy to get the clot out of the way, and then they treated the bifurcation lesion with 2 bare metal stents. Okay, so we're not going to code it in exactly that order, because I think the principal procedure would be the dilation, and we'll just put the thrombectomy second. So 1 code for the bifurcation lesion with 2 bare metal stents and a 6 at the end for the bifurcation. And then not forgetting our extirpation, which is just at 1 site in the right coronary and done percutaneously, of course. All right, I sincerely hope that I have laid out the possibilities for you and that you will feel comfortable coding the bifurcation, and hopefully we're going to nail it, get it right every single time. All right, now let's move next to open procedures. We'll leave the percutaneous behind, and we'll move on to coronary artery bypass grafting. And I'm going to do a really quick review of this. This may not be new for many of you, but there could be some of you who don't work on this kind of thing, open heart surgery, all the time. So let's do that review to set the stage, and then that will allow us then to jump from there to the more complex or unusual bypasses. Coronary artery bypasses just divert blood. It just around a blockage, send it farther on downstream so that we can keep the heart having a blood flow. And this is CABGs. The body part value here for the coronary arteries gets counted the same way we code it for all procedures on coronary arteries. So the number of arteries treated, and you can combine things into 1 code if they use the same approach, the same device, and the same qualifier. Now here, I want to point out that I don't want you to forget that coronary arteries are special. The heart's very special, and these are the bypasses that are backwards. So they're different from all the other bypasses of the body, and that the qualifier value is where the blood comes from, the source of the blood. And then I also want to point out in this slide that the device value can be tricky here. The device value is if they use a synthetic, which doesn't happen often, but they can, or if they use a non-autologous device, no problem. We just have to be careful when they use the patient's own tissue to do this bypass. So if it's the patient's own tissue, it has to be a free graft, totally separated from the body, in order to be listed in the device value. And in fact, this is that way in every root operation in PCS. We will see in my examples that they will tend to use the left and the right internal mammary, which are not, those arteries are not completely disconnected from the body and used as a free graft. So they don't get a device value, and I'll help with that. So the qualifier value is the source of the blood. And in here, I did write that there's one tricky spot in our qualifier options. It says you can use another coronary artery as the source of the blood. And I kind of put it in there so that we could talk about it. This is where your alarm bells should go off if you are attempting to code the a coronary artery as a source of the blood. That would mean we're going to steal blood from another coronary. Now, while I assume it certainly can be done, I suspect that this is an extremely rare case because I've never actually seen one. So if you do happen to come on a report that you believe is actually stealing the blood from another coronary artery, I would love to see that case, okay? So feel free to send it to me because I want to see that. It's in there and it gets chosen incorrectly some of the time because it just seems like a great thing to pick. Most other bypasses of the body, the other bypasses work in that direction. This one works backwards, okay? All right, so now let's look at a drawing of the 3 most common types of coronary artery bypasses done here in the US. I say that because in other countries, these are not the 3 most common. And I'll show you later what I mean about that. But we're going to take our bread and butter and work on these cabbages first. On the left side of the picture, you can see that the left internal mammary artery has been used as a pedicle graft, not completely disconnected. Just get it from the chest wall on the one end, swing it down and hook it past a blockage. So this is the one where we're not going to have a device value versus the 2 that are on the left side here of the image, that there's a venous graft, kind of the blue colored one, most commonly the saphenous vein. And that one is treating one coronary artery and it's getting its blood from the aorta because you can see it sewn on there. So that's going to be our qualifier of W for that one, as is the next one, the arterial graft. That one's red, and that one highly likely to be a radial artery graft. And that would also have the blood source as aorta. So let's look here at the table in TrueCode and see that I was just starting to build that venous graft. So autologous venous would be my device value, and my selection for that, for blood, for the qualifier, the source is the aorta. Don't be called off by the shiny object of number 3, coronary artery, okay? All right, and then here's the image again with the codes on it that go with these basic grafts. So you can see that the left internal mammary has no device, and the ones on the left side, the venous and arterial free grafts, they do have their own device values. And then the reminder that those have to be harvested to turn them into graft material. All right, now that's basic cabbages. However, there are plenty of times where the patient's clinical situation is not going to work with a plain vanilla normal old cabbage. We're going to have to do something specific for that patient's anatomy or their situation. So the first kind is a special graft that usually is referred to as a Y or a T graft. It looks in the black circle there as an inverted Y, but some surgeons call it a T because it kind of looks like a lazy T on its side. Depends what you want to do with it. I think some people don't think of it as a Y because it's upside down. Either one means the same thing. It's going to branch. So this is not a bifurcation situation. This is 2 bypasses with the same source of blood. And you might say, well, why would the surgeon do this? Why doesn't he just run 2 tubes? Well, maybe they don't have a whole lot to use. and they need to get these 2 bypasses done. So if the left internal mammary is long enough, they could cut a piece off and rehook it. They could use a radial artery like shown here in the picture. So either they don't have a piece long enough to do it, or they need to get additional from somewhere like the radial artery, or they have blockages that are in unusual places that would require the graft to take a really tight turn. And my note there says, which will not work. The surgeon knows that to keep the blood flowing smoothly and not clot and not cause a problem, no kinking, they have to make sure that their grafts lay very straight or take very slow curves. So they didn't have enough to do this and make a correct curve, so they got out an additional piece and used the device. So let's assume this is done with the radial artery, and we have 2 codes to describe this. We have the plain vanilla left internal mammary that we just had, and that has no device and a 9 at the end as the internal mammary as a source. But then we treat an additional coronary artery in a different way. So here comes a separate code. 1 coronary artery with autologous arterial tissue, and the source of the blood, when you trace it backwards, is still the left internal mammary artery. So this is our first special graft. Now the next special graft is using both the left internal and right internal mammary. You have one on both sides. And so this one, they just disconnect them out on the ends. They're through the same, probably midline sternotomy here, and they can take them and use them to treat either one each for a coronary artery or multiples, okay? And it depends on how long those vessels are. Now, in a very short person, the vessels are short. In a very tall person, they may be much longer and have lots of conduit. So this right here is the most common configuration that is used with my European client. And yes, there are countries other than the US who use PCS. In Spain, they didn't even want me to teach about saphenous veins because this is what they do. They say that there's far less redo work based on this. So 2 codes look almost alike, but the qualifier on the end of one is for the left and on the other is for the right. And no free grafting, no new connections to make, just 2 things to sew. Much easier to perform as well. It's done here in the US. I've seen this, but not anything consistently. So one day I was looking for a really good picture of these before I had my custom drawings done, and I found this cartoon. It has more to it. It is from Europe. It had foreign language on it, but they still call it the left internal mammary and the right internal mammary here. And you can see the plumber has a heart under the sink, so it's just all about the plumbing and how you're going to reroute the blood flow. All right, now the next 2 are a particular scenario for when the patient has the right posterior descending artery, the one that I mentioned that goes down to the bottom of the heart and wraps around the backside. Very hard for the surgeon to get to. So in this case, there's 2 options that they can use to fix this. They also may use this technique if the patient has had CABG in the past and now comes back and has to have an additional bypass done, and they're out of tools to use. Now, as you can see in this picture, this looks really different. This is called the Gastroepiploic Bypass. And without seeing a picture of it, this kind of might blow your mind if you're trying to figure out what's happening in the coding. So for this one, it takes a second surgeon, usually somebody laparoscopically taking the end of the gastroepiploic off the greater curve of the stomach and sending it up through the aortic hiatus, so up through the diaphragm where the aorta comes through, and then using it on the bottom of the heart. And so this one has a special qualifier that says abdominal artery, and we know that because it's below the diaphragm as the source of the blood. They're just routing it upward because blood flows upward, no problem. Now, the second option that they can use that can be done by just a cardiac surgeon alone is to do a graft extension. So they can take the right internal mammary, if it's not very long, and they could add an extender another artery. They don't want to combine a vein. It doesn't seem to work very well, but they do use radial artery extender or even a piece of left internal if they're working on the left side as well. They're going to use an end-to-end anastomosis, like in the black circle, and they're going to literally lengthen the right internal mammary to build one bypass. So really important here, only one bypass going on. And if you think about what they're doing, they are using a device to augment a body part. So you guessed it, the additional piece has to be accounted for in a supplement, which makes the right internal mammary longer. So it's not two bypasses. Don't get confused. Only one coronary artery being treated here. So the first code, if they use the left radial artery as their extra piece, we would have a bypass from one coronary artery from the right internal mammary, and we're going to increase the length of the right internal mammary in the 0-3 table with autologous tissue substitute. In that table, it doesn't split out between arterial and venous. So it takes two codes for that, plus you would have to account for the harvesting of the left radial. We don't know where it came from, so I just picked left. All right, now in the circle there, they use an end-to-end grafting technique. And so that's this one on the left in the picture. But they have other techniques that they can use for our last special kind of graft. And this is a jump graft or a sequential graft. So for this, it's like they take that vessel and they hop from one coronary artery to another to fix as many as they can. So the side-to-side technique that's in the middle is going to be for any of those intermediate stops or the hop that the artery takes. And then the final stop is going to be the end to side, because that's like the termination. You have to quit now. And so I tried to find a good picture of this. I do not have a good drawing of a sequential or jump graft. So I took it out of the textbook, out of the FAHIMA textbook, just to show this to you. And here they're using the left internal mammary, and the heart is kind of turned by this artist. And they have one end to side as the stopping point, and kind of hard to see, but there are two of them as side to side. So this left internal mammary was able to handle 3 individual named arteries. And here is what our code looks like. And it's 3 sites, but the body part value is 2. Again, no device. It's all still connected, and 9 for left internal mammary is the source of the blood. All right, now that is the end of the traditional and unusual open coronary artery bypass grafting. The next thing, as I promised, is percutaneous endoscopic coronary bypasses. And you might be saying, oh yeah, sure, what in the world is this? Well, last year I started preparing to teach some of these cardiac programs, and I just Googled unusual cabbages. And what came up was amazing. I couldn't believe we'd ever be able to use this percutaneous endoscopic approach value in our 0-2 table. What came up was something called TECAB, totally endoscopic coronary artery bypass on a beating heart. And I found this in an article that has a fabulous video that is right within the article. So at the end of your handout, you'll have a bibliography, and you'll have a couple of coding clinics about the bifurcation, the textbook, and you'll also then have the link that you can go and read the entire article and see the video if you want. But I will tell you, it's real heart surgery. Now, I have selected still shots from the video, and I tried to keep it as not bloody as possible. But if at any point you're not good with that blood, just close your eyes and just listen to me talk. Okay, so the video starts out by very nicely having them have the 2 fingers pointing at what they're going to try to fix with this procedure. The patient has a blockage in the left anterior descending and the diagonal branch, so 2 uniquely named arteries. And in order to do this totally endoscopically, they are going to use portholes. So these portholes work with a robot. This is a robotic assisted procedure. I'm still amazed by the fact that these surgeons can use this console to do all of this work. So they're going to use portholes that account for all of their devices. You get 5 of these holes, which I think a whole lot better than a sternotomy. You get the left arm and right arm, which are the traditional holes, plus down towards the middle, down by the armpit is the camera port because it's dark in there and we're going to need to see. And then more towards the sternum, there's a 4th arm. It's going to be the stabilizer, and I will show you drawings and pictures of these instruments. And then the last one is the largest hole, which is red there. And this is for what they call Flex A accessory port. And this is for the special instruments that they developed to do this procedure. Some amazing person figured if I just had the right tools, I could get this thing done. This is from the University of Chicago Medicine, and you can watch the whole video. I did clip out their drawings and a few still shots to help me try to understand this and explain it. That accessory port is going to use this instrument called a Cardica C port Flex A distal anastomotic stapler. Too much to say, but you know, there's special GI staplers and other special staplers, and somebody probably figured if I would just build a stapler. Well, one of the things that you can see in the left-hand side here is that there are staples in part of the stapler on the top, and then there's what's called an arteriotomy knife and an anvil on the bottom, and that's going to come together to staple, and I'll show you. Let's keep going now to the right. The blue arrow points at the hole for the anvil, which is a little poker part that's going to go into the target vessel, the LAD here, and then it's going to pull it up towards the stapler so that the staples do not fire through the back side of the artery. You don't want that. That would do no good. Then the arteriotomy knife is going to cut where that dotted line is. So before they do that, they have to do a couple things. They're going to have to get that left internal mammary harvested and skeletonized, take off all the fat. Also, notice in the picture, it's labeled as internal thoracic artery, LIDA. It's the same thing. It just depends, I think, on where you were trained as a surgeon. The first thing they do is make that little anvil hole, and they put a drawstring or a purse string suture around it so that when they pull out the anvil, they can just pull that suture tight and it'll hold up the hole right away. So the anvil here is loaded with the artery, and I'll show you another drawing in a second of what that really looks like. But they're going to put that in, they're going to deploy the stapler, and in the inset picture on the bottom right, you can see that the artery, the left internal mammary, is coming down and got stapled into the LAD, and there's that little anvil hole, but they're going to pull those sutures and close that hole. All right, now, here's what the instrument actually looks like. The genius doctor developed and had built for this procedure. On the left-hand side, the stapler is upside down, and that's what they do to load it. They're going to spatulize and open up the end, the left internal mammary, put it in the holder, and then that's on the right-hand side. You can see that the artery is in there and nicely like fluted out so it can be stapled. To do the procedure, though, they are going to turn the stapler over. So there's the name of that thing again. And then here's what it looks like when they've turned the stapler over. The anvil is in, and they're going to fire it. This is a mock-up. They used fake tissue to show us what the staples would look like when they're fired. And you can see that those two arteries are now nicely connected and the blood would flow right through there. This is just amazing to me that it can do an end-to-side anastomosis with this stapler, okay? So they don't have a stapler for the other anastomosis, but they do for this one. The next one, they'll have to do freehand. So when they take out the stapler now, they pull those two sutures there on the anvil hole, pull them tight, and that's done. Now here comes the second piece of the bypass. This is that intermediate stop. They did the first one was the distal, and now they're going to put in an intermediate stop, and they are going to use shunts. So that up in the right there, the angled picture is the best one I could find of the shunt inside the vessel, and while they're sewing, the blood just flows through, and the heart just keeps beating. This is a beating heart, no cardiopulmonary bypass. And the way they can do this is with these little shunts. Now, to me, I'm so sorry, it just looks like pasta. It looks like a penny pasta on a string or on a wire. And that's what it is. It's got beveled edges like that, and the blood can flow through. So they are going to loop off the vessels just so they can get the shunts in, and then they can make the blood flow again. And they're going to use a white one and a turquoise one in each vessel. So here they are putting in the white one into the diagonal branch, and you can see how that bevel is just going into the vessel where the blue arrow points, and it will have the wire to hold it so they can get it back. Here comes the turquoise one now going into the internal mammary. Then they're going to start to do, once they get them both in place and you let the blood flow go, so the heart's still got blood, they are going to do a side-to-side technique with the 2 shunts. So here you can see that they've started to put their sutures in to get them together, and you can see the shunt, and I guess in the one you can just see the wire sticking out. So this is going to be hand sewn, and the blood's still flowing. And now they've got their sutures all in place but loose, and now they're starting to take out those shunts. So they put the vessel loop on, hold the blood back for just a little bit, and pull that shunt, and then here they are pulling it out, and then we do the other one the same way, and the shunts then are out, and they tighten and do the final suture closure. So this is what it looks like when the shunts are out and they're just finishing closing up. Now, the important part about this is we can't forget the robot, okay? When I coded this the first time, I wanted to forget the robot. It takes 1 bypass code because 2 arteries are treated the same way. The source of the blood is the left internal mammary because they're sequential, and this is the percutaneous endoscopic approach, and the code looks weird, but it's correct. It's got a 4 for an approach, a Z for no device, and 9 for the source of the blood, plus a robot that is for the trunk region, also percutaneous endoscopic approach. All right, I hope I've actually shown you something that you've never seen before and that you thought it was interesting. I have the bibliography, and the link that's on the bottom here is in your handout, and you can watch the entire video and see it happen. I think I am ready now to head on to questions, but I wanted to leave on the screen the place that you can go to receive your FAHIMA CEU credits. We get this question a lot after the webinar, so I'm just going to leave it there as we open up for questions. What kind of questions have come in? Karen?
Great. That was an excellent presentation, Lynn. That was very exciting to see that at the end. I certainly had never seen that before. We only had one question that was about the presentation today, and that was actually back in example 3. And the question on example 3, and I don't know if you got it to the side or if you need to pull it up on the screen, but she says, does it matter which one the bifurcation qualifier was attached to?
Okay.
I'm making you go way back in the
I'm
presentation.
going to leave this up
Sorry
on the
about
screen.
that.
That's the one that had,
Okay.
That's okay, that's no problem. I have a printout here, but I do want to leave this about the CEU credit right there while they can copy it down. Example 3 was we had a fork between the left anterior descending and branching into the diagonal, and they put a stent in the LID, but they only angioplasty the branch. And I had said back then that there really aren't any rules about this, so it's a good question. I put the bifurcation qualifier on the code that contained the device, and I put that as the first code. I actually don't think that it matters, but if I have 2 angioplasty codes and one has a device and one doesn't, I tend to put that one first because it's really fixing a problem and it's expensive, and I just want to make sure it gets up there in the principal diagnosis position, principal procedure position, if it is what relates to the principal diagnosis. So I just chose to put it on the one with the device, but I don't think that it's wrong to put it on either one. We don't have any guidance. So you can certainly do what you like there. But I put the one without the device second, and I put it, of course, without the bifurcation. Bifurcation only goes on one because you don't want to say to the data we have 2 bifurcations. Okay? All right. Don't be shy. Please put your questions in because this is the time to get questions answered.
We have another question, and this is on example 4. And hang on a second, it moved away. So if you want to pull that out on question number 4, or example number 4, and then let me move this back up where I can see it again. Oh, would that imply 3 stents were put in on that one?
Yes, and they did. They got 3 stents put in. I think that the CEU thing may have been up there long enough. I can come back to it in a bit, but let me see if I can, because this one bears going back to. This was probably the hardest one of those cases that we were looking at. Let's go back to the original intervention. There are 3 stents that got used. There's a resolute stent in the LAD, in the proximal circumflex, and in the mid circumflex. And they're all different sizes, so there have to be 3 individual devices. And so when I got to the end here, we have 3 unique places. I ended up with a combination of 3 arteries, but not all in one code, and 3 drug-eluting interluminal devices, 2 on the first code and 1 on the second code. So they account for all the devices and all the arteries, but separately because only the mid circumflex had the bifurcation. Okay. If there's more of a question to that, let me know. Put it back in. But for right now, I'm going to go back to the end and make sure that everybody captures their CEU. Okay.
And actually,
you will see a survey tomorrow as well, but invariably this question will be asked.
And we have, Sharon, if you're listening still, there are several people that are saying they're unable to access the link, link to the evaluation. So Sharon, if you got a different link, or if you're going to fix that and send it out to them.
Yeah, I just hadn't made the link live yet. I usually wait till the completion of the webinar, but I just made it live. So try it again and it should be working.
Great, thanks. And Lynn, one more question for you on slide 11. It says you have 2 arteries on slide 11. And the question is, isn't the circumflex and the obtuse marginal branch considered one main artery?
Let me get back there.
Sorry?
No, they're individual branches. Good question. The obtuse marginal is its own named vessel. Okay, so if you go back to slide 9, I think, where I listed coronary arteries and their branches. We don't really care about names to assign a code, but for the geography, the only you count them based on their own individual names. Okay, so the right has 2 branches, so there's 3 possible arteries there. The left has 1, 2, at least 3, 4, 5, and maybe 6 that are all on the left side of the heart. And patients may have an intermedius, a ramus, a bunch of other stuff that is unusual anatomy. But each one of those named arteries are considered a coronary artery when you code.
All right, thank you. We have one more question, and that is, someone asked, is cardiopulmonary bypass still used?
If they mean on that TECAB, on the totally endoscopic cabbage, no. That's one of the things that they talk about in the article, that the beauty of this is that there is no CP bypass required. The heart's beating all along, and only when at the time, for the least amount of time, that they have to be closing stitches or putting in a shunt, do they use a vessel controller, the vessel loop, to just close it off quickly, do their work, open it up right up again. And so they do not require any CP bypass. On cabbages, the secret to whether you need the bypass machine is whether or not they have to do significant work in connecting the grafts to the aorta, because you just can't open up that aorta and let the fire hose go and let the bleeding happen. They can cross clamp it potentially for one that they can put in kind of a sneaky little place, but when they need to do more than one, or they need to do other stuff, creative stuff with these grafts, then they're going to go on CP bypass. But for the robotic endoscopic one, no bypass. Heart beats the whole time.
That's amazing, just absolutely amazing. Well, I think we're just about out of time. Sharon, did you need to say anything else to our participants here at the end?
It's true. Okay.
Yeah, I just wanted to reiterate that there will be an email coming tomorrow morning that will not only have the link that you can see on the screen, but it will also have a link to handouts as well if you need those. And I want to thank Lynn and so much for this presentation. The comments are, Karen and I are reading the comments and they're very, very positive. So thank you, Lynn, for a great presentation. And thank you everybody for taking the time to join us today.